Good evening and very warm welcome to all of you on this integrated YouTube live session with me, my colleague and friend Dr. Deepali. She is pediatrician and myself Dr. Harmeet Goel. I am a gynecologist and we are taking the integrated Obs Gynae with pediatrics session MCQs discussion for upcoming exam of INI-CET 2023. Now this session is going to be helpful for upcoming exam of FMG and later on the NEET PG as well. So welcome you all. So the first question I am taking up is a 37-year-old lady, primi gravida, came to gynae casualty with history of 36 weeks plus 5 days of pregnancy with gestational diabetes. She gives history of acute pain abdomen, bleeding per vaginum. Her blood pressure is taken and it was recorded as 150 by 100 millimeters of mercury. On examination, her fundal height is approximately 36 weeks. Uterus is tense and tender. Fetal heart rate is 100 per minute. Her random blood sugar was conducted, which was 180 milligram per deciliter. She is carrying an ultrasound report done at 32 weeks of pregnancy showing that the placenta is in upper segment. So in the question, information given to us is that placenta previa is already been ruled out because she has a third trimester ultrasound. Had it been a second trimester ultrasound, we need to repeat the ultrasound for placental localization because placental migration occurs till 28 weeks. So even if it is a low-lying placenta, as the pregnancy proceeds, the uterus grows up, so the placental site is, also elevated. So maybe in an early ultrasound, when you get a low-lying placenta, in the third trimester ultrasound, the placenta may be upper segment. Okay, so she is carrying already a third trimester ultrasound. Now, what will be your management in this case? Number one, admit and do conservative management till 40 weeks because we know in diabetics, the lung maturity of the baby is delayed. Number two, take consent and prepare for emergency cesarean section. Number three, induce labor by oxytocin drip. Number four, give steroids for fetal lung maturity. So let me check up the chat. Thank you so much for appreciation. Now, let us go further. Welcome Dr. Ravi and others. Now, what have you marked? Now, in this question, let us just check and read the question once more. Number one, risk factor given is 37-year-old primi gravida. So this is elderly primi gravida, which is risk factor number one. Number two is gestational diabetes. Okay. Then she gives a history of acute pain, abdomen and bleeding, and the blood pressure given is 150 by 100. Of course, in the question, previous record of the blood pressure is not been mentioned. So this is risk factor number 3, that is showing preeclampsia. Okay. And there is, almost the fetal heart rate is towards the lower side. So this is a very, very high risk pregnancy. High risk pregnancy, and many of the risk factors are mentioned in this question. Okay. Only my concern is a lung maturity, and after I finish, my colleague Dr. Deepali is going to emphasize on the lung maturity, what are the problems this baby can have. So many risk factors present. There is a 25% association of diabetes with preeclampsia and 25% association with polyhydramnios. One important thing you have to remember is in gestational diabetes, there is no chance of fetal congenital malformation. So my concern is lung maturity, but since it is a 37-year-old female with PIH, with abruptio placentae, because there is a tense and tender uterus. So I am going to admit this patient, take her consent, high risk consent, because lung maturity may be a question mark, and I am going to prepare for an emergency cesarean section. Now we follow that there is a universal screening for diabetes in pregnancy. Diabetes in pregnancy is very upcoming topic, and we go by the DIPSI criteria, that is diabetes in pregnancy group DIPSI criteria, where universal screening should be done. So first screening for diabetes is on the first ANC visit, and the second screening is done between 24 to 28 weeks of pregnancy, and irrespective of the fasting status, a pregnant lady should not be fasting. So why 24 to 28 weeks is selected? Because at this time the insulin resistance is very high, so it is the best time to screen for diabetes. So we give 75 grams of glucose and we take the blood sugar levels after 2 hours. So cutoff value is less than 140 milligram %. There is another criteria like International Association of Diabetes in Pregnancy Study Group, where there is a 75 grams of glucose and fasting 1 hour and 2 hour samples are being taken. So the cutoff values is 92 milligram per deciliter, then 180 and 153. This is very important in various PG entrance exams like AIMS, like INI-CET. They have already asked this cutoff values. Now we prefer, according to India, the DIPSI criteria, where the cutoff I said is less than 140, and it has been asked in majority of the exams. Now the less than 140 is normal. If the value comes out to be between 140 to 200, then we label it as gestational diabetes, and it is usually developing after 20 weeks. If the value comes out to be more than 200 milligram %, it is pre-gestational diabetes. So there is a risk of congenital anomaly in pre-gestational diabetes because hyperglycemia, a good glycemic control is very important, and in the preconception phase counseling is done and folic acid supplementation are added to prevent neural tube defects, and good glycemic control is very important, and then the lady can plan the pregnancy. Once she becomes pregnant, she should be switched over to insulin, because insulin is the drug of choice for diabetes in pregnancy, as insulin do not cross the placenta. One important risk of diabetes is if the blood sugar levels are very high, baby develops macrosomia. If the insulin dose is given very high, the baby develops hypoglycemia and stillbirth. So managing a case of diabetes is really a tricky situation in our country. Now, why hyperglycemia? Why the pre-gestational diabetes? There is a risk of congenital malformation, because hyperglycemia leads to the buildup of free radicals which are fetotoxic. Okay, so let me ask Dr. Deepali to further emphasize upon this, and we will take up more questions.
Okay. So we have this child, this is delivered in this scenario. The baby was delivered by emergency LSES and was found to have a birth weight of 3.8 kgs. All of the following are anticipated complications in this baby, except, now we know we are dealing with an infant of diabetic mother. That is very clear. Ma'am has explained us very well. Now, how do we go about the complications? So, starting with the first complications, she has already very well explained that the congenital anomalies, they are prone, the baby is prone to develop, the fetus is prone to develop these anomalies if the mother is having pre-gestational diabetes. This is a question that has come in your previous exams. You have to listen to this. So, in pre-gestational diabetes, these children are, the fetuses are prone to develop congenital anomalies. That is how we start the complications seen in infant of diabetic mother. So what is that known as? That is known as diabetic embryopathy, and usually it is if the blood sugar levels of the mother are very high, specifically in the week 5th to 8th of gestation. That is the period when majority of organogenesis is taking place. So there the chances are high that the child goes on to develop, the fetus goes on to develop congenital anomalies, and topping the list over here is congenital heart defects. That is, so these defects are enlisted over here in the order of their decreasing frequency. So the maximum number or the system which is most affected in terms of congenital anomaly is the heart defect. And the most common congenital heart defect seen in an infant of diabetic mother is VSD. And the most specific congenital heart defect seen in this case is TGA. So TGA, I would just write down over here. Most common fetal anomaly is cardiovascular anomalies, right? So cardiovascular defects, with VSD being the most common and most specific being TGA. That is transposition of great arteries. Although other congenital heart defects can also develop like TOF. So you should remember this. Then the other other congenital anomalies which develop are the CNS defects, the urogenital defects, the limb defects, and the orofacial clefts in the decreasing order of frequency. This should be very clear. Another thing which you need to keep in mind and very commonly asked in your exam is the most
characteristic.
Yes, the most
characteristic congenital anomaly seen in the baby of diabetic mother. And it was asked, Dr. Deepali, last time in the NEET PG 2020 exam, there was a question and they have asked this image and they have asked, what do you think this can occur in? So it was given gestational diabetes or pre-gestational diabetes. What's your answer?
Yes.
Let us see. Yes, Dr. Shubham is writing very correctly. The VSD is most common and TGA is most specific. Sacral agenesis is most specific. That is very, very correct.
Although one must remember that sacral agenesis is rare, but it has been seen that if you take up the total number of cases of sacral agenesis, 25% of them occur in those children who are infants of diabetic mother. So sacral agenesis is one of the classic findings of diabetic embryopathy, number one, and it's considered to be the most specific, most characteristic congenital anomaly. So that you have to remember. So that is, these are all your MCQs we are discussing right now. Okay, and other than these, so we are starting with the complications. The first complications we handled was the congenital anomaly, and as we move further, what other complications can occur in these children? Of course, mortality can occur at any point of time. It can be a third trimester intrauterine death. It can be a stillbirth, and I will tell you the reason as we move forward. And yes, these children are prone to develop macrosomia. Why? So let us start with the reasons why all these complications occur. The main reason behind all these complications is hyperinsulinemia. And why hyperinsulinemia? Because these fetuses, the fetus encounters high maternal blood glucose levels, and this leads to hypertrophy of the islets of Langerhans in the body of the fetus, and this leads to excessive secretion of the insulin in the baby circulation. Now we all know, this is another MCQ for you, that the main growth hormone during the fetal period is insulin, and if the insulin levels are high, then insulin causes overgrowth of many parts of the body, and the basic target organs where the insulin acts is, this also you have to remember, it is liver, it is muscles, it is subcutaneous fat, and one more thing, that is heart. These are the 4 target organs which come under the action of insulin, and that results in macrosomia or the large baby. And because of a large baby, these children are prone to develop birth injuries during the labor time, and the most common, again ma'am will tell us, is shoulder dystocia, right? And apart from that, these children are prone to develop premature birth because of the coexistent complication of PIH. Like in our case, the baby delivered was a borderline term, and one of the complications coexisting with diabetes was PIH, right? Then these children are also prone to develop respiratory distress syndrome. Why? Because high insulin levels, they interfere with the maturation of surfactant. So that is why these children are prone to develop hyaline membrane disease even if they are born at term gestation. So this should be very clear that infant of diabetic mother are prone to develop HMD or the respiratory distress syndrome. Then another complication is hyperbilirubinemia, that is because of the immaturity of glucuronide transferase system, and these children also have polycythemia, and polycythemia also contributes to hyperbilirubinemia. Now the question arises, why polycythemia? So polycythemia occurs because of increased erythropoietin secretion in these children. The question arises, why increase erythropoietin? It is because that high insulin levels. If I tell you there is one single villain in the a story of an infant of diabetic mother, and that is increased insulin levels. So these increased insulin levels, they increase the metabolic rate, and when the metabolic rate increases, the oxygen demand increases, and because of increased oxygen demand, the placental circulation is not able to keep up with this increased oxygen demand. So these children are usually in the fetal state, in a state of chronic hypoxia, and this chronic hypoxia stimulates erythropoietin secretion, and this erythropoietin obviously causes increased production of RBCs, and this increased production of RBCs leads to polycythemia, and of course this also leads to hyperbilirubinemia and also to renal vein thrombosis, one of the very common complications seen in infant of diabetic mother. What else? Yes, the classic complication, deliberately I have kept it lower down, hypoglycemia. We all know these children usually on day 1 of life. Typically the nadir in the blood sugar level in these children usually occurs between 1 to 3 hours of life, and that is why these children have to be specifically, the blood sugar has to be readily monitored. Pre-feed levels are supposed to be monitored at least for 36 hours of life, because these children have increased insulin levels, and that is what makes them prone to develop hypoglycemia. Then coming on to hypocalcemia, that is another complication, but remember about hypocalcemia, the serum calcium levels, they take a dip usually between 24 to 72 hours of life. So what question you get in your exam is that if an infant of diabetic mother is having a seizure on day 1 of life, what is the most likely reason? It is hypoglycemia first. Yes.
And if 24 hours have passed and then baby is throwing a fit, what is the likely cause?
Yes, it is going to be hypocalcemia.
So remember, hypoglycemia is the most common cause of convulsions in first 24 hours of life in a baby of diabetic mother. And next is hypocalcemia.
And hypocalcemia, it will be your answer if it is said that the baby was stable in the first 24 hours and in, let us say, at 28 hours of life or at 30 hours of life throws a convulsion, then your prime diagnosis will be hypocalcemia, because it is unlikely that if the child has been stable in the first 24 hours, because that is the time when the glucose levels will take a hit down in the downward trend, and at that time if the child has been stable, it is unlikely that the hypoglycemia will contribute to the child having seizure beyond 24 hours of life. So we have to understand beyond 24 hours of life, the answer should be hypocalcemia. Now what are the causes of hypocalcemia? There are many causes of hypocalcemia. It can be simple because of prematurity. That can be one of the cause of hypocalcemia. It can be because of hypoxia. It can be because of hypoparathyroidism, right? And then it can be because of some disturbance in the vitamin D metabolism. It can be also because of hypercalcitonemia. So these are the few causes of hypocalcemia seen in infant of diabetic mother. And then another very important cause of hypocalcemia is hypomagnesemia. So whenever we go for calcium, serum calcium estimation, we have to also go for serum magnesium estimation. So any level, serum magnesium level less than 1.5 milligram per deciliter qualifies as hypomagnesemia. We also have to correct this, otherwise their hypocalcemia does not get corrected. So that is also one of the cause of hypocalcemia. And these children usually have small left colon distal to the splenic flexure. So this is, and that is how it presents as delayed passage of stools. And then we get confused whether this child is a case of Hirschsprung or not. But please remember, infant of diabetic mother, if passing delayed passage of stools, you should suspect small left colon syndrome. Usually by enemas this gets corrected. Nothing more is required in this. And of course there is one more reason, one more complication for infant of diabetic mother, and that is poor feeding. So poor feeding can be related to coexistence of other complications like HMD in these children, or prematurity, or simply without any cause these children are prone to develop poor feeding. So this is the complete list of complications which you need to know. Now let us come to that question. So what we were dealing with, and that is that in the previous scenario the baby was delivered by emergency LSCS, was found to have a birth weight of 3.8 kg. All of the following are anticipated complications in this baby except hypoglycemia. Yes, we just learnt about it. Hypercalcemia, of course this is not the complication. Renal vein thrombosis and polycythemia, yes, we have read about it. So definitely the answer is hypercalcemia. This is not a complication seen in infant of diabetic mother, right? And there was this one more thing when we talked about congenital malformations. In pregestational diabetes, it correlates with increased HbA1c levels in the first trimester, specifically in the 5th to 8th week of gestation. And ma'am will speak about it right now.
Now, glycosylated hemoglobin is very, very important in any diabetic case. So it becomes more important in a pregnant lady because it will tell us what was the glycemic control in the previous 3 months. The more the value of glycosylated hemoglobin, there is associated risk for congenital anomalies. Okay, if there is, like the value comes out to be 8.5%, then there is around 8 to 10% risk of fetal congenital malformation. If the value of glycosylated hemoglobin comes out to be more than 10 or 10.5, then there is a 25% associated risk of fetal congenital malformation. So this is very, very important.
So coming on to the next question related to this is, which is the most commonly injured bone during delivery? So the answer here is it humerus, is it clavicle, is it femur, is it skull? It is definitely the clavicle. Clavicle is the most commonly injured bone, and the intervention what we do over here is, in fact, nothing to be done. We just pin the sleeve of the child to the shirt of the child for kind of immobilization for some time. Usually by day 7, day 10 of life, the callus develops, and then that signifies that yes, the bone is on the road to healing. And usually the clavicular fractures usually go undetected. Usually they are actually caught at day 7, day 10 of life with the callus formation in that area. The parents bring the child back to us, and then they show us, and then we come to know that yes, this child has suffered from a clavicular fracture, but nothing more to be done beyond this. Talking of this, let us move on to some nerve, most common nerve to be injured while getting a baby delivered in the mother.
What I am trying to mention here is like the most common problem associated with the delivery of a pregnant diabetic lady. Okay, if it is already a diagnosed case and she is coming for a regular antenatal checkup, we always do serial ultrasound to check the growth of the baby, to check the growth of like the growing fetus, and which is the most important or sensitive diameter that we consider is we measure the abdominal circumference of the baby. It is not the weight which is important, it is the abdominal circumference, to label it macrosomia. Okay, incidence of macrosomia is nearly 40% in diabetes. Okay, and management is a elective cesarean section. Okay, but if the pregnant lady is unregistered or she has not come for any antenatal checkup, she just lands up in the labor room for delivery, the most common problem is the delivery that is what is shoulder dystocia. So shoulder dystocia means the head is delivered and shoulders are the ones which are stuck up, because in macrosomia baby, the baby puts on lot of weight on the shoulders. So the diameter becomes more than the maternal pelvis diameter. Okay. So we have to do different maneuvers, and you should remember this. Like one of them is a Mac-Roberts maneuver.
Dr. Shubham Gupta is asked.
Yeah, that's fine. Now, Mac-Roberts maneuver is that, you know, like you have to apply a suprapubic pressure, and you have to, you know, like flex and abduct the leg of the female in order to create a space and try to deliver. This maneuver shown because you might get a question on the shoulder dystocia and the maneuvers. So Mac-Roberts maneuver. Next are the other maneuvers, Wood's maneuver, Zavanelli's maneuvers, and finally, if these maneuvers are not getting successful, it is said that you put the head back into the uterus and perform an immediate cesarean section. Now, while doing a Mac-Roberts maneuver, which is the most common nerve that can be injured in this pregnant lady, is the lateral cutaneous nerve of thigh. Lateral cutaneous nerve of thigh. So this question has already been asked in one of the PG entrance exam. So shall we move to the next question?
Yeah, we'll do the next question now.
Okay. Now a 38-year-old female, and one thing I want to mention it here is stillbirths are likely to take place in diabetics. So monitoring is very, very important. In the monitoring, the biophysical profile, the non-stress test, like we do weekly in, for example, it is mild preeclampsia, but here we have to do it more frequently. Glycemic control of the mother is very, very important. So we have to switch over to insulin because that is the drug of choice. In gestational diabetes, we try to maintain on the, you know, like diet control, and regularly we keep on checking the blood sugar. It can be done on the OPD basis as well, but if the sugars are high, it is not under control, we have to switch over to insulin.
So taking a point over here, again I would like to emphasize that the villain in the infant's story is hyperinsulinemia, and that is connected to maternal hyperglycemia. So you can explain each and every complication happening in infant of diabetic mother on the basis of hyperinsulinemia, and that is how, you know, you have to manage these children depending on whatever complication they present with.
In today's session, you will find all the obstetric questions which are high risk pregnancy. We have selectively, you know, specifically selected so that gynae and peds can be discussed in a very, very integrated form. And please do expect the clinical questions are going to be asked in this scenario. Now let us take up another question. 38-year-old female, gravida 5, para 1, L0A3. So it is 5th time she is pregnant. One baby she has delivered, that might be a stillbirth or a neonatal death, but she does not have any live issue, and there are 3 abortions, and she is admitted at 32 weeks of pregnancy, and that too with preterm labor pains. Her blood pressure is normal, but there is a history of previous 3 abortions and 1 preterm delivery where baby could not survive. So what is your best plan of management? Give tocolytic agent and continue the pregnancy. Prepare her for an immediate cesarean section. Give tocolytic agent, do NST and give steroids, or admit and do cervical encerclage operation. Number 1, 38 years age is important. Number 2, gravida 5 and no live issue. This is a case of bad obstetric history. Now, any doctor, whether in a government sector or a private sector, will always do an elective cesarean section in view of bad obstetric history. Nobody can challenge this answer. But mind it, my dear students, it is 32 weeks of pregnancy. So what is the primary concern about this? Is fetal lung maturity is a concern. Okay.
Yes.
What? A gynecologist or an obstetrician, it's very easier for us to do a cesarean section.
No, I don't think so. But okay,
you know,
still.
like, but the problem is the neonatologist, because हमने तो baby deliver करा दिया and handover कर दिया.
कोई नहीं मैम,
if
handle करेंगे अच्छे से.
so let us focus on this question. What do you find this a clear-cut history of APLA, that is anti-phospholipid antibody syndrome. Just to make it revised for you, this is a SAFRO criteria where there is, there is a deep vein thrombosis and it is affecting the mother and the child both. In the child, what happens? It causes placental infarcts. So blood supply to the growing fetus gets affected. There is chances of abortion. There is chances of preeclampsia, IUGR, oligohydramnios, and IUD. In the mother, there is stroke, there is transient ischemic attacks, deep vein thrombosis, then in the gangrene, then renal shutdown. All these are the systemic problems. Now, what about pregnancy? Let's just talk about. There is a history of abortion in less than 10 weeks or one abortion occurring, one or more abortion of more than 10 weeks, but there should not be any structural or chromosomal defect in this case. That is very important. Okay, because most common cause for first trimester abortion is chromosomal. Okay, and second trimester abortion is cervical incompetence or malformation of the uterus, and there is one preterm delivery or loss of 34 weeks of pregnancy or less. Okay, so this criteria is very specifically met in this case. 3 abortions and 1 preterm baby has lost, so APLA. So this mother must have given low molecular weight heparin. That is very important. In this question, we will not go for immediate cesarean section. We will try to arrest the preterm labor pains and give steroids so that fetal lung maturity can be attained. So I am in favor of tocolytic agents, and the best tocolytic agent and the first line tocolytic agent is nifedipine, which is very safe and it is very well preferred. Do NST, that is I am going to check what is the fetal heart rate pattern and I am going to give the steroids. There is no role of cervical encerclage, and just giving tocolytic agent will not help. You have to have steroids to the pregnant lady to cause fetal lung maturity. Now this is a reactive NST where you check the different fetal parameters, the baseline, the beat to beat variability, and there is presence of acceleration. If NST is recorded like this, there is a difference between NST and CTG. NST is done when the patient is not in labor. CTG is done when she goes into labor. Okay, so steroids, there are 2 types. There is a beta-methazone and there is dexamethasone. Beta-methazone, it is 12 milligram, 2 doses, 24 hours apart. This is very important because sometimes they ask a direct question on the beta-methazone dosage and they have already asked. Dexamethasone is 6 milligram into 4 doses and 12 hours apart.
Basically over a period of 2 days. That is DEXA, how it is given. So the dosages has to be learnt properly. This is
very important, beta and DEXA dosage.
Life saving for us, for the neonatologists.
Okay. So what are the problems this baby born? Suppose we try to, we are just gaining some time for fetal lung maturity. That is what is an idea of giving the steroids. But she goes into active labor pain and the baby is delivered. What can be the problems that can occur?
Okay, so before going into the problems faced by the preterms, we will first see this question. Administering antenatal corticosteroids prior to preterm delivery decreases the incidence of all except necrotizing enterocolitis, respiratory distress syndrome, intraventricular hemorrhage or pathological hyperbilirubinemia. So as you know, in preterm deliveries, steroids are a blessing for us because they decrease the incidence of many morbidities in the children, and these are a necrotizing enterocolitis, respiratory distress syndrome, definitely, intraventricular hemorrhage. I will not stop over here. It also decreases the incidence of PDA, that you should know. It also decreases the incidence of infections in this preterms. Incidence of infection is also decreased. What else it does is that it also decreases the NICU admissions and the overall hospital stay, and it also decreases long-term neuro impairment. So such is the blessings, you know, given by the steroids if they are given properly in the antenatal period. And usually
let us check up what are the students writing their answers, and we can see
Yeah,
many
so
of
they-
them are, you know, like writing with very, very correct answers.
Yes. So the correct answer, of course, over here is pathological hyperbilirubinemia that is not prevented by giving steroids, right? And what else in steroids? While giving steroids, one should keep in mind that the proper action of antenatal steroids come only when we give a period of at least 24 hours for them to act, and the action lasts for the coming 7 days. So if the delivery is postponed, let us say to 3 days or 4 days, very well we need not repeat the dose of steroids because the action would still be there. So this should be very clear. Okay, now coming on to the
Now, can you just emphasize which is the most important, you know, like the basic difference between physiological jaundice and a pathological jaundice?
Of course. So the first and the foremost thing you should know that the physiological jaundice would never come in the first 24 hours of life.
Yes, very
right?
important.
So that is very important, and the rate of increase of physiological jaundice is less than 5 milligram per deciliter in 1 day. And moreover, physiological jaundice, you know, it usually comes after the first 24 hours of life, and it usually disappears by 7 to 10 days in a term child. So that is it. And preterm it might be there a bit longer, but anyways the levels are also very important. Usually in a term child it does not cross a level of 12 to 15, and in a preterm it does not cross the level of 15 milligram per deciliter.
And what can be the very, very important cause of pathological jaundice in a newborn baby?
Of course it is going to be RH incompatibility.
That is very, very important.
Yes, so with the mother being O negative, right, and the basically any RH negative mother with the baby being a RH positive. It can be anything A, B, C, A, B or O, right? So that is it. Then let us come to the problems of preterm. Let us do that. So this is this is actually a newborn is born prematurely at 32 weeks of gestation, is found to have paradoxical breathing, marked chest and xiphisternal retractions, minimal nasal flare and expiratory grunt audible only by stethoscope. Calculate the Silverman score for this neonate. So we know we are talking about Silverman-Anderson score. So there are usually two types of scores used for assessing the severity of respiratory distress. One is the Downey score. So you know this was more prevalent during when we were doing our PG, and then they started addressing Silverman-Anderson score more as compared to Downey score. Okay, just okay.
So many students are writing, wow,
Just
great answers from you.
Okay, Silverman-Anderson score, right? And now let me discuss the parameters what we assess in Silverman-Anderson score. So we see the upper chest retractions, you know this, upper chest retractions are seen. Then lower chest retractions are seen. Then xiphisternal retractions are seen. So very simple to remember. And then we also see the grunting, and we also see flaring of nasal alae nasi. So flaring of alae nasi. So these are the 5 criteria on which the scoring is done, and scoring is somewhere 0, 1 and 2, and anything more than 4 indicates a total score of 4 indicates respiratory distress, and anything more than 6 indicates impending respiratory failure. So let us calculate the score for this child. So paradoxical breathing, yes, we give the score of 2 over this is the nothing but a seesaw kind of respiration. Then marked chest and xiphisternal, so you get 2 again for each. So this is 6. Minimal nasal flare, you get a score of 1, and expiratory grunt audible without a stethoscope gets a score of 2, but audible only by stethoscope gets a score of 1. So the total score, if you add up, is going to be 8. So the correct answer over here is the D option, that is 8. Now coming on to the preterms, the first thing, the first complication.
No idea, ma'am.
No idea? You don't have an idea? So
About this.
Silverman-Anderson score is very commonly asked in your AIMS exam. This is a repeat question what I am discussing with you. So you should know this score by heart. They can again ask you, you know, in this exam. So I have already told you these are the parameters on which you score them. And the parameters are given a score of 0, 1 and 2. So this is a repeated question which I am discussing, nothing new out of the
This
book.
is very, very important
Right.
that she has mentioned it is a repeat question, so you must focus and learn the things.
Yes.
Idea of these integrated sessions is like to give you additional information and to boost up your confidence with the previous questions or answers which you already know. So something have to be add on what you are having your knowledge with. That is what is an idea of these sessions.
Yes, and Zen Mode has written Silverman lower the better for newborn. Yes, of course, the lower score it is better. So this is just unlike Apgar score. In Apgar score, higher score is better. But in Silverman-Anderson score, if it is a lower score, then obviously it is better. If it is a higher score, that means impending respiratory failure for the child. Right? So this you should be knowing. Now let us move on to our discussion on the most common complication encountered in a 32-weeker preterm, and that is HMD, hyaline membrane disease, or as we call it, respiratory distress syndrome. We know the problem is the deficiency of surfactant. The surfactant production, it peaks at 35 weeks of gestation. So it is seen that any child usually who in the newborns who who are delivered before 34 weeks of gestation, they land up with the problem of hyaline membrane disease, especially if they do not get sufficient time for the steroids to act, right? And so like in this case, if we don't give 24 hours for the antenatal steroids to exert their action, these children are prone to develop hyaline membrane disease. How do glucocorticoids help? Glucocorticoids help in induction of the surfactant. Now the next question comes, how does surfactant helps? So there were two questions in this NEET PG which were based on just the action of surfactant. So they asked these two questions in a different way, but the answer was the same. How does surfactant help? Just imagine, so when we are breathing inside, the alveoli, they inflate. When we expire out, the alveoli deflate, but they do not deflate fully, right? But what happens in a preterm child is they deflate fully, and then it is very difficult to again inflate them. So this surface tension is lowered by surfactant. It prevents the atelectasis, it prevents the deflation of
Can
the
we
alveoli.
say it is preventing the collapse?
Of course,
of
yes.
the lungs.
So it is preventing the collapse of the lungs. It increases the functional residual capacity of the lungs, and that helps in the proper gas exchange. So this is the function of the surfactant. Now this surfactant is lacking in a child who's, let us say, is born at 32 weeks of gestation. So what will happen? This child lands up with respiratory distress. So what are the markers of respiratory distress? Yes, the child will be having something called grunting. What is grunting? This is also asked in your exam. It is forced expiration across a closed glottis. The child is trying to maintain a pressure inside the lungs, and that how the body adapts to is by closing the glottis and then expiring. Normally while expiration, the glottis has to be open, but here the child tries to expire against the forced glottis so that the pressure is built up inside the lungs and the alveoli do not collapse, right? So we get to see grunting, then we get to see retractions. So what are retractions? Retractions are the area, the part of the chest wall, it goes inside with it collapses inside. So this is known as retractions. So this is also one of the marker of respiratory distress. What else we get to see is the increased respiratory rate. So this tachypnea, in other words. So these are all the features of respiratory distress. These denote increased work of breathing. The child is working more to generate a proper, to ensure a proper gas exchange. So now we have to help this child, otherwise this child will go into respiratory failure. So what do we do is, the first modality is we start the child on CPAP. Now the question arises, why CPAP? So CPAP is, we give the air oxygen gas flow is given under a pressure of somewhere between 4 to 7 millimeter of water, right? And then this helps in this increased pressure, helps in keeping the alveoli in an inflated state, and this ensures a better FRC, functional residual capacity, and then this ensures a better gas exchange occurring. So CPAP is an excellent modality in this case. What are the indications on which we start a CPAP? So this is initial stabilization for spontaneously breathing preterm neonate in a delivery room. We can, start the CPAP right in the delivery room. And if the Silverman-Anderson score is more than 4, and if the FiO2 requirement is more than 30%, we know if the child is maintaining saturation, maintaining his ABG right in the room air, then it is 21% saturation. But if the child is requiring more than that to maintain a saturation of 90% or a PaO2 in his ABG of somewhere between 50 to 70 millimeter of mercury, then we know that this child requires more oxygen. It is better to start not to increase oxygen but give him under pressure in form of CPAP. Please remember, at the end of the day, oxygen is also a drug. It is very harmful to the baby if given in excess amounts, especially in preterms. It causes lots of damage, and the most potential complication of giving excessive oxygen is retinopathy of prematurity. So we have to balance somewhere in between.
Even I was not knowing this. So
oxygen
discussions, more knowledge is added to us also.
Today
I was not aware.
Today I am very enlightened as far as ops people, ops management goes. Although we stand there in the, in the OT and the delivery room just passively waiting for the baby to come out, we are least bothered about whatever, decisions they are taking. But the moment she started speaking, oh my God, this also happens. So this is actually an enlightening session for me also. So, okay, anyways, so these are the indications for CPAP. Of course, on this, we can also decide to give surfactant. So when we decide to give surfactant is on CPAP, if the FiO2 requirement is somewhere between 35 to 40%, and we are seeing that the baby is not very comfortable, that means retractions are still there, the baby is still trying to grunt, so that means we have to also give surfactant to this child. So how do we give surfactant in this cases? This is something known as Ensure. So this is known as Ensure. What is Ensure technique? You intubate the baby. So in CPAP, we don't intubate the baby. But in CPAP, if the child is on CPAP and we have to give surfactant, the only mode of giving surfactant is through endotracheal intubation. It is a kind of intratracheal installation of surfactant. We cannot give surfactant by IV or oral or any other modality. This should be very clear. So for a baby on CPAP, CPAP is delivered through a nasal cannula. So the child is not intubated. So what we do is that we intubate the baby, we give surfactant, and then we extubate the baby. Usually it is said that within 10 to 15 minutes of giving surfactant, we can extubate the baby and get the baby back on CPAP. So this is known as the Ensure technique of giving surfactant. This is asked in your exam. You should be knowing.
So,
right?
Surfactant injection has to be given in a baby born with hyaline membrane disease or a respiratory distress, and it is given endotracheal.
Right.
This is very important. This is the message that Dr. Deepali has very well emphasized. So you should be knowing this answer.
But now what happens? Let us see another degree of HMD. For example, the child is on CPAP but is requiring more than 50% of FiO2. I told you, we just cannot increase the oxygen like that. So if the requirement is more than 50%, if the child is having frequent apneas, or if the child's CO2 is building up, is the building up in the blood, we are doing a ABG and seeing that the PCO2 in the ABG is 65 millimeter of mercury, and there's increased work of breathing even on CPAP, then it is better to put the child on a ventilator and then give surfactant over there. Got it? So this is how you manage a case of HMD. So these indications you need to know, because you get scenarios in your exam and then they will ask you, what are you going to do? But please remember, the first modality, if the child is having mild to moderate, maybe a moderate kind of respiratory distress, a CPAP is a very attractive option because it is non-invasive. And of course then with mechanical ventilation, if the distress increases, we have to go for that modality. Okay, then one more more thing I would like to tell you over here is, nowadays there is, you know, new kind of modalities coming up, something like low invasive surfactant administration, LISA, or minimally invasive surfactant administration, MIST. So in this they are saying that you need not intubate the baby, you just use a catheter and push it down the trachea and then instill the surfactant through that catheter. But this is an upcoming modality, I have just told you, because you know you are going to appear for your INI-CET exams, you should know the upcoming modalities also, right? So this is how HMD is managed in a case of preterm. I'll take up the
different colors.
Okay.
One more thing, Dr. Deepali, I would like to ask.
Okay.
Like, is there any role of bag and mask ventilation or ambu bag if a baby is born with HMD? Is there any rule?
So ma'am, if the child is not breathing, initially we will do the bag and mask ventilation only. Then the CPAP does not help. CPAP is indicated only in a spontaneously breathing child. Please remember that. So bag and mask ventilation is a part of neonatal resuscitation. If the child is born apneic, the first thing is I'm going to discuss steps of resuscitation. So first would be the initial steps. If still the child continues to be apneic, then we will go for bag and mask ventilation. And of course, in that case, if the child still is not breathing properly, then we go for chest compressions, and with chest compressions we usually intubate the child. So CPAP has no role in a child who is not spontaneously breathing. This should be very clear to you, right? If the child is spontaneously breathing, then we can use a CPAP. Okay. 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 So I think we move on to the next question now.
Yes.
Okay. Sure.
Let us take one more question, and this is on the Doppler ultrasound. There's a 34 weeks of pregnancy. A primary gravida was admitted in the ward in view of IUGR with oligohydramnios. IUGR, and there is oligohydramnios on a recent ultrasound. Okay. Gynecologist got a Doppler ultrasound done, which showed, because Doppler ultrasound is very, very important in cases of preeclampsia, in cases of IUGR with oligohydramnios. Okay, and this was done, and it showed a reversal of diastolic blood flow in the umbilical artery. So normally when the Doppler ultrasound is done, this is the blood flow pattern. This is something which is normal. Okay, so first of all, there is absent diastolic blood flow. Okay, there is absent, and finally there is reversal of diastolic blood flow, like this figure is showing. So the pressure is very, very high, and already there is a pre-existing IUGR, which is a chronic placental insufficiency. There is premature aging of the placenta, there is fibrin knots, there is calcification in the placenta. So already there is a compromised condition where the blood supply to the fetus is going very, very less. So there is a very much role, and many times the Doppler ultrasound in IUGR along with oligohydramnios is been done regularly at intervals starting from as early as 28 weeks of pregnancy. So if I get such an image after getting a Doppler ultrasound, it is for me to decide a termination of pregnancy. Otherwise, this baby will develop IUD. So reversal of end diastolic blood flow from the umbilical artery is very important or ominous sign that this baby is going to develop IUD. And at 34 weeks of pregnancy, we can terminate the pregnancy, because in these babies, one good thing is lung maturity is not that much problem. Lung maturity is a problem in baby of diabetic mother, but in cases of preeclampsia, chronic hypertension, IUGR, lung maturity occurs early. Now IUGR, intrauterine growth restriction, the expected fetal weight is less than 10th percentile, or abdominal circumference is less than 10th percentile. Moderate IUGR, the expected weight of the baby is between 3 to 10th percentile, and severe IUGR is it is less than 3 percentile.
Okay, so now I take over. Ma'am has given me a IUGR baby. So what are the anticipated complications in IUGR babies? Let us see. So all of the following are anticipated complications in IUGR babies except. So hypoglycemia, of course, we know this is an anticipated complication because anyway is going to have low glycogen reserve. Then polycythemia, yes, whatever insult has caused this baby to develop IUGR, intrauterine growth restriction, definitely the end point of that insult is the baby is in a state of chronic hypoxia, and this chronic hypoxia is going to stimulate our erythropoietin, and that's why these children have polycythemia. Then birth asphyxia, because they are small, they are growth restricted, they do not withstand the stress of labor very well, so they are prone to develop birth
Sorry for
asphyxia.
interruption. I just said, like lung maturity is not a problem. So please do not get confused with birth asphyxia and lung maturity. That's what?
Yeah. So if we talk about lung maturity, there are various, in your questions, in your previous PG entrance questions, there have been questions where they have, even given an option that heroin addiction by the mother, it augments the lung maturity, and that's a correct statement. So this was one of the statement given that what all augments the lung maturity: toxemia, hypertension, and heroin addiction by the mother, for that matter even the female sex. That is a good marker. Usually the lungs would be more mature if the sex of the baby is a female. So these are certain markers of the lung maturity. Okay, let us come back to our question here. IUGR babies. So birth asphyxia, as I was telling you, they don't withstand the stress of the labor well, so they are prone to develop birth asphyxia. And why anemia? So see, anemia and polycythemia will not coexist, but of course these children are also prone to develop anemia. So maybe in some IUGR you will see polycythemia, and in another you would see anemia. So why anemia? Because the turnover of fetal RBC is very very fast, this. And another thing is that these children have decreased reticulocytosis. Reti count is decreased in these children, so therefore they are prone to develop anemia. Another reason for anemia is that their iron stores are also compromised. So this is the reason that they are also prone to develop anemia. So don't get confused that the answer could be either polycythemia or anemia. No, all these four complications are seen in children of children who are growth restricted in the intrauterine period. So the answer over here is going to be none of the above. So that is why I deliberately put in this a tricky question for you. Now coming to the management of IUGR babies. So first of all, we should know that there are two types of IUGR which we encounter: symmetrical IUGR and asymmetrical IUGR. So symmetrical IUGR means that these children have encountered some kind of insult in the early part of the gestation, usually in the first trimester, and that kind of insult would be something like a congenital anomaly or a genetic defect,
or can be a torch infection,
or can be a torch infection. Very well,
this is very important.
Yes, so that these are usually symmetrical IUGR. And why symmetrical? Because their entire body would be small, including the head size. The brain is also affected in the symmetrical IUGR because organogenesis is taking place in the first trimester, so the brain development is also affected, number one. Number two, the number of cells, it is the hyperplasia which is affected. So the total number of cells is decreased in symmetrical IUGR, while in asymmetrical IUGR it is the hypertrophy of the cells, the cell enlargement is affected. The total number of cells is same as a normal baby in asymmetrical IUGR, while in asymmetrical IUGR the insult usually occurs in the later part of gestations. It can be secondary to toxemia, preeclampsia, whatever, the maternal kind of insult. It can be because of vasculopathy occurring because of diabetes. See, diabetic children, infant of diabetic mothers, are not always macrosomic. They can be IUGR also, especially if the diabetes is so much uncontrolled that there occurs some irreversible changes in the placental vessels, which we call as placental vasculopathy. So if these children, if these mothers, they develop vasculopathy, that is going to affect the development of the baby, and this child lands up with IUGR, most likely a asymmetrical IUGR, right? So this is the difference between in asymmetrical IUGR, the head circumference will be normal. In fact, the head size would be larger than the rest of the body, so hence the name asymmetrical IUGR. Now there is one more way of how we distinguish between between asymmetrical and symmetrical IUGR, and that is by calculating the ponderal index. So what is ponderal index? It is weight of the baby in grams divided by the length of the baby in centimeters,
Third power of female length.
in centimeters, and that is cube. So weight upon length cube. So first I was writing length of the baby in centimeters, and it has to be cubed. So weight upon length cube into 100. So this gives you the ponderal index. So ponderal index will be less than 2 in asymmetrical IUGR. This should be clear to you. And it will be greater than, ponderal index will be greater than 2 in symmetrical IUGR and also in normal babies, any normal baby. So this you should know. This is asked in your exam to calculate the ponderal index. That is my next question. So ponderal index of a neonate, you have the weight 2 kg. So first you will convert it into grams, that is 2000 grams divided by length of 50 centimeters. So this is how we are going to do it. Cube. So 3 times multiply and then multiply it by 100. So what is the answer we are expecting over here? Yes, so answer we are expecting is 1.6. So this is the answer. Of course, here I am seeing on the chat that asymmetrical babies are prone to develop hypothermia. The IUGRs, yes, they are prone to develop hypothermia. Why? Somebody has asked me this. It is because the skin of the child is very thin and friable, number one, and number two, there's a large surface area as compared to the weight of the child. So that is why they lose lot of heat, and yes, they have scarcity of brown fat. The brown fat is very less in these children, and as you know that in normal children, in normal babies, usually it is the brown fat that helps in heat generation. But in IUGR babies, as well as in preterm babies, the brown fat is less, and that is why both of these categories are prone to develop hypothermia. I hope I have answered your question. So this is this is how the IUGR babies behave. What are the other complications seen in IUGR babies? Yes, we can see congenital anomalies, especially as ma'am told, the torch infections. If they contract torch infections in the first trimester, so congenital anomalies will be more in symmetrical IUGR. Then these children are also prone to develop hyperbilirubinemia because of immaturity of glucuronide transferase system, number one, and number two, because of the polycythemia. As we have just seen that because the RBC mass is more, so obviously that will give rise to hyperbilirubinemia. So these are all the complications which we have discussed with IUGR babies, right?
And
so,
one thing
yes.
I just want to emphasize that doing a Doppler ultrasound, apart from other, like we go for a biophysical profile, we go for an NST, in these cases, in the antenatal period, Doppler ultrasound is very, very important. And what is the blood flow pattern in various vessels we record? It is the uterine artery blood flow pattern, umbilical artery blood flow pattern, and middle cerebral artery. Middle cerebral artery of the fetus, because in asymmetrical IUGR there is a brain
Sparing effect.
So what do you expect here? It may be a vasoconstriction, but in middle cerebral artery of the fetus there is vasodilatation which is seen. So this is again very, very important that you should remember. Uterine artery, umbilical artery will show, like the vasoconstriction pattern, but in the middle cerebral artery of the fetus, it is a brain sparing effect. So this is very, very important for you to understand and remember. Shall we take another question?
Okay, yes. Let's do that.
Let's take up 28-year-old priming gravida came to the labor room with a history of leaking per vaginum. Leaking per vaginum since last 24 hours. On examination, her pulse rate is 100, that means she has tachycardia. Blood pressure is 100/60, temperature is 100 degree centigrade Celsius. Per abdomen, fundal height is 36 weeks. There is uterine contractions present. Fetal heart rate is 170.
तो मैम ने यहाँ तय किया है सारा रायता फैला के देंगे आज मुझे।
बिल्कुल बिल्कुल। डिस्कसिंग हाई रिस्क प्रेगनेंसी, नॉर्मल प्रेगनेंसीज तो मेजॉरिटी होते हैं, उसमें तो कोई डिस्कशन ही नहीं होगा।
And as you know,
we have
हमारे
selected the
yes.
like high risk pregnancies and more emphasize कि गायनी ऑप्स के तो आंसर्स आप निकाल लेते हैं. What about the pediatrics? So let us add on. And once we are going for a next learning pattern, that is NEXT pattern for the upcoming exam, pediatrics has got the importance and the marks and the number of marks of pediatrics has been increased.
60
that is why we have planned this session so that more of the pediatrics can be discussed, and that can be discussed in creating the high risk. And most of the questions, like depending, keeping in mind what is the present pattern, I have made it. And Dr. Deepali has added up the questions which has already been asked and some of the questions she has created. So if you try to find out, you will not get easily. Let me just tell you. So we wanted to discuss, like, fetal tachycardia is also called as fetal distress, number one. Leaking per vagina more than 24 hours is again a risk factor for chorioamnitis. Okay, so this is very important. Per vaginum examination, cervix is 3 centimeters dilated, station is -3 station, fetal membranes are absent. Leaking is more than 24 hours. There is temperature of the mother raised. There is, like tachycardia of the mother, tachycardia of the fetus, and already she is having fever. And, like some of the investigations are also written. So total leukocyte count is again more. It is 18,000 per cubic millimeter. CRP is raised, ESR is raised. So it is almost signifying that it is a case of chorioamnionitis.
And for us, neonatal sepsis. Chalo,
yes,
ma'am, batao.
So what is your next plan of management? Start antibiotics and do a cesarean section in view of chorioamnionitis. Augment labor with oxytocin drip. Admit and give antibiotics. Monitor labor. Give antibiotics. Continue till full dilatation of cervix and go for an instrumental delivery. So what's your answer? Let's just check.
सब सही दे रहे हैं मैम,
बढ़िया.
हम बहुत अच्छा पढ़ाते हैं सारे हमारे गायनेकोलॉजिस्ट. देखो सारे कॉन्सेप्ट्स आर क्रिस्टल क्लियर. वेरी गुड.
देखो मुझे इसमें पीडियाट्रिक्स का डिस्कशन भी चाहिए, और पीडियाट्रिक्स का टू बी वेरी वेरी फ्रैंक, अगर गायनी के क्वेश्चंस दिए जाएं एंड पीडियाट्रिक्स के, तो गायनी के मैक्सिमम लोग जो आंसर्स फिर भी निकाल लेंगे, बट दे गेट स्टक अप इन पीडियाट्रिक्स एंड सो मेनी न्यू थिंग्स वी आर लर्निंग. सो हियर रिमेंबर, नॉर्मल fetal heart rate. Normal fetal heart rate pattern is 110 to 160 beats per minute. Less than 110 we call it as fetal bradycardia, and more than 160 we call it as fetal tachycardia. Both means fetal distress. So this is clear. This is leaking, premature rupture of fetal membranes have occurred, that is fetal membranes rupturing before the lady goes into labor, and there are all features of sepsis present. Now how Dr. Deepali is going to manage this case? So most of it is we are discussing from the neonatology point of view. So
Okay.
let us see this case.
So let us say this child came to us, on day 2 of hospital stay. Newborn develops refusal to feed and lethargy. So this child, the scenario which has been described by ma'am. A panel of tests is conducted on this newborn and antibiotics are started pending investigation results. The panel of tests done include all except, what I am talking about. I am talking about sepsis screen, right? So what is not included in the sepsis screen, that's what they are asking you. So is it CRP? Is it TLC? Is it IT ratio, or is it urine culture?
What
so
is
we know
IT
that
ratio?
So it is immature to total neutrophil ratio.
Okay.
So what is IT ratio? Okay, good ma'am has asked. I'll just elaborate it for you. So what happens is, it is seen that during neonatal sepsis, you know, the output of the bone marrow increases suddenly. So the bone marrow starts throwing immature neutrophils into the circulation. So if the percentage of immature neutrophils increase, that is a marker for us that yes, the child is going into sepsis or has sepsis, right? So if there is more of immature neutrophils to the total neutrophils, that means the IT ratio is raised. And what is the cutoff? More than 20%, right? So if it is more than 20%, that means the bone marrow is supplying immature neutrophils into the circulation, and that's a marker for us that the child is in neonatal sepsis, right? Okay, so what is not included in the sepsis screen? So we know CRP is included, TLC is included, IT ratio is included, and there are two more parameters which are included. One is ANC, that is absolute neutrophil count, and the other is micro ESR. So these are the 5 things which are included in the sepsis screen. And what are the cutoff? CRP should be elevated. I will not tell you a single value because that depends on the lab which is processing the CRP. So anything above the cutoff of the lab is taken as CRP, positive CRP. Then TLC in neonatal sepsis is, please remember, it is decreased, right? Total leukocyte count is decreased, that is less than 5000 millimeter per millimeter cube. So this is decreased. ANC is also decreased, that is less than 1800 millimeter cube, and IT ratio is more. So why IT ratio is more? Because the immature neutrophils has increased, right? So that is more than 20%, and micro ESR is also increased, that is more than 15 millimeter in per hour, right? So these are the criteria. Any 2 positive tells you that the sepsis screen is positive and we have to start antibiotics. But anyways, now first let us discuss, if a child in this scenario had, you know, on day 1, or if I had been witness to this delivery, what is the rule, or how do we manage these children? So anyways, if the child is having symptoms, then definitely we have to start antibiotics. If the child is asymptomatic but is having the setting which ma'am just told us, then what is the criteria in which I start antibiotics? So 3 things you have to remember. If the mother is having chorioamnionitis, that is ma'am just discussed, if this is the case, or if the mother is having foul smelling liquor. And the third is if the rupture of membranes 72 hours have passed. If any of these 3 criteria is positive, then I will not wait for the symptoms to develop in the neonate. I will start antibiotics straight away. But before starting antibiotics, 2 things have to be done. First, blood cultures have to be sent. So remember, blood culture do not come into sepsis screen, but still they have to be sent, number 1. Number 2 is the decision about doing a LP. So whether we do a LP or not, tell me, what is your opinion on this? So let us see. Okay, so here people are answering or not able to answer probably. So what are the indications of doing lumbar puncture? Please remember, before starting antibiotics, we have to do a lumbar puncture also. So that means the whatever decision we have taken to start antibiotics, lumbar puncture has to be done. In asymptomatic neonates, where I have not started antibiotic, what is the decision about LP? The decision is that if the blood culture has come positive, so there's a asymptomatic neonate, there are no risk factors, but I have done the sepsis screen and I have sent the blood culture, and the blood culture comes out to be positive, please do a lumbar puncture. So these are the 2 indications of doing LP. First is before starting antibiotic in a symptomatic neonate, or in an asymptomatic neonate where the blood culture has come positive, one has to do LP. Now gone are those days where we were taught, you know, that early onset sepsis is more about pneumonia, and the late onset sepsis is more about meningitis. Of course it still exists, but lumbar puncture has become that much important, and the reason is the features of meningitis do not present in a usual manner in the neonate. They are often obscured. So that is why we don't want to miss anything. Depending on the LP findings, we have to guide our duration of antibiotic therapy. Otherwise we will miss and this child will not be treated well. Now let us come to the two types of sepsis which we see, the early onset neonatal sepsis and the late onset neonatal sepsis. So we call it, if you remember, EONS and LONS. So what is the difference? Let us just enumerate over here. So EONS usually develop in less than 72 hours of life and LONS develops anywhere between 72 hours to day 5 of life. So that is, or maybe we can just say that after 72 hours of life. Then what else? The source of early onset neonatal sepsis is the maternal urogenital tract. Usually we see if the mother is infected, then the child has a tendency to develop early onset neonatal sepsis. In late onset neonatal sepsis, the predisposing factors are many, because usually the organisms, they come from the community, number one. So what can be the predisposing factors? Maybe inadequate breastfeeding or any disruption of the skin barrier, or umbilical sepsis can be one of the predisposing to neonatal septicemia. So disruption of, let me write this, disruption of skin barrier. So these are some of the predisposing factors to the late onset neonatal sepsis. Of course, the presentation in the early onset neonatal sepsis, the commonest presentation is respiratory distress. This you should know. And one of the feature of early onset sepsis can be simple septicemia or pneumonia. Please don't think that respiratory distress means pneumonia only. Respiratory distress is the commonest presenting feature. That can be a presenting feature of septicemia also without any lung involvement per se. But of course, pneumonia is also seen in early onset neonatal sepsis. In late onset neonatal sepsis, you can have anything from septicemia or pneumonia or meningitis. Is that clear? And then the organisms, if we talk about early onset neonatal sepsis, usually what we see in our country is either Klebsiella or E. coli. Or over here in the late onset neonatal sepsis, you can see Acinetobacter. You can also see things like cons, coagulase negative staph. Another predisposing factors of late onset sepsis is if we have done any kind of intervention when the child was in nursery. It can be umbilical catheterization or it can be any kind of other intervention. Even that predisposes a child to develop late onset neonatal sepsis. So this you should know, and then accordingly we manage sepsis.
This is again very, very important point which she has very well emphasized, that meningitis, please don't consider it is early onset. It comes under late onset. That is what is very, very important here.
Okay. So I think we are done with this. Now now that I have told you, let us do this question. In the given scenario, which of the following statement is correct? Lumbar puncture is indicated only if blood culture comes out to be positive. Lumbar puncture is indicated only if the newborn develops signs suggestive of meningitis. Lumbar puncture is done if the baby does not show any signs of improvement even after 48 hours of antibiotic therapy, or none of the above. So what do you think is the correct answer? So the correct answer over here is none of the above, because LP is indicated only if blood culture comes out to be positive. No, LP will be also done if we are going to start antibiotics. So before starting antibiotics in any child, LP will be done. LP is indicated only if newborn, this is not the scenario. And LP is done if the baby does not show any signs of improvement. Again, this is not the scenario. So deliberately I had put in a tricky question, because you are going to give a big exam in the coming days and you should be very well clear with the concepts, right? Okay, I think we are done with this scenario. Okay, one more thing is there. So all of the following are true about neonatal sepsis except jaundice can occur, leukopenia is common, Fever is a common presenting feature. Lack of breastfeeding is a risk factor. We read about this. Yes, it's a risk factor for late onset neonatal sepsis. Leukopenia is the usual presenting feature. We know that TLC drops to less than 5,000 and ANC becomes less than 1,800. And jaundice can occur. Of course, it can occur. Please remember, conjugated jaundice or conjugated hyperbilirubinemia can be a manifestation of neonatal sepsis. Now, fever is a common presenting feature. This is a wrong statement because usually neonates present with hypothermia. Please remember that temperature instability is written in your books, but what does that mean? That means most likely they will present with hypothermia. Rather than mounting a temperature increase, their temperature decreases. So this is a wrong statement about neonatal sepsis. I think we have done everything about neonatal sepsis. Now let us move on to the next scenario. Handing over to you, ma'am.
Yeah. So this is a case which I have taken. In this case, the pregnant lady is unregistered, unbooked case. She just landed up in active labor and patient was quickly shifted to the delivery table. So the question is, 28-year-old lady was brought. Brought always means either she is in active labor or the condition of the patient is not good. So brought को थोड़ा सीरियसली लेना चाहिए. अदरवाइज क्वेश्चन आता है पेशेंट केम टू गायनी ओपीडी और गायनी कैजुअलिटी. ब्रॉड का मतलब ब्रॉड इज समथिंग लाइक समथिंग टेकन, मतलब you should consider that case. Okay, in the labor room she started delivering the baby in breech. Nowadays breech has become an indication for cesarean section because of the risk of asphyxia. Okay, now this baby was delivered till the neck of its own. Cervix is 10 centimeters dilated and cord pulsations are felt. This is very, very important. If such a case comes, you have to first feel for the cord pulsations, and one of your team, whether it is a sister, whether it is paramedical staff, or whether it is your junior doctor, should call the relative and take a consent. That let the things be on the relative's head because it is them, they have brought the patient in late labor. What will be your next line of management? Shift her for an immediate cesarean section. Baby is almost hanging till the neck. Cervix is fully dilated. Okay, cord pulsations are present. Okay, cut the cervix and deliver the baby and hand over to the pediatrician for resuscitation. Give episiotomy and perform a burn Marshall technique or start oxytocin drip immediately. What's your answer?
So we are getting mixed kind of answers, right?
Write down your answers. Lot many students are attending the session.
So I think A and C is in response to your answer, to your question.
Okay. C. Cutting the cervix will not help because cervix has already done its job. It's the full dilatation of cervix, so you do not gain anything. You have to give episiotomy and perform the burn Marshall technique, that is for after coming head of breech. Cutting the cervix. If you are cutting the cervix, suppose this is 8 centimeters or 7 centimeters dilated, cutting the cervix, patient will be in a pool of blood because cervix is very, very vascular structure during pregnancy, and like the doctor who give a cut to the cervix, that is called as Derson's incision, and doctor should be qualified enough to stitch that also. One more thing, you can't hold the cervix with the like Valsalem forceps. You need sponge holding forceps, and you cannot take a continuous stitches. You have to take interrupted stitches, and you have to maintain the hemostasis. All this is very, very important in cervical tear. Okay, so here the problem is not at the level of cervix. So I am going to give a episiotomy. I am going to call a pediatrician. I am going to call an assistant to give a perineal support. Otherwise this episiotomy can get extended to the rectum, and I am going to perform the burn Marshall technique. Burn Marshall technique is like, with one hand I am going to hold, and with another hand I am going to put like my fingers onto the neck, give a downward traction and deliver the baby towards mother's abdomen. That means the head is to be born like this. Okay, so head is already in the extended posture. We have to give the flexion and deliver the baby. Another technique of delivering the after coming head is the Morrissey's Milliviate technique, that is a jaw flexion and shoulder traction technique. So you should be knowing about the maneuvers, like Pinard's maneuver is used for breech with extended legs, and Lofset's maneuver is used for breech with extended arms. Now in this case, since it is an unbooked case and she came in the active second stage of labor, she is already delivering, so the baby came out to be very, very limp. Now such a baby is been handed over to the pediatrician and let her explain the neonatal resuscitation part, which is very, very important. As a doctor you should know, and even while I was doing my post graduation, our teachers told us to learn the neonatal resuscitation, and I must admit I can intubate a baby much better than an adult because baby फटाफट revive हो जाते हैं if your intubation steps are correct, but adults में तो
this is the reason I took up pediatrics. The results are really rewarding, right? Okay, chalo, let us
take up this question,
okay.
And this is the last question we are taking up.
Last question.
Okay, let us see.
Chalo, let us see. So the baby has come out limp and apneic, and what would be the best step of intervention in this case? So we know nowadays delaying cord clamping has come into neonatal resuscitation, and because it increases the hematological status of the baby, so it is said you delay the cord clamping by 30 seconds to 1 minute till the cord stops pulsating. And what do we do is we just make the baby lie down on the abdomen, chest and the abdomen of the mother. Chest in the case obviously if the cesarean section has taken place. So we just make the baby lie down like that, and we wait till the pulsation of the cord stop, and then we delay, and usually it takes around 30 seconds to 1 minute, and then we clamp the cord. So this is the usual procedure which is done in a baby in which we can see that the baby is breathing well. But any sign of compromise in the baby, the delayed cord clamping has to be abolished. So we have to go for immediate cord clamping. But then let us see what do we have over here in the choices. So the child has been born limp and apneic. So delay the cord clamping by 30 seconds and then perform the initial steps. Immediately clamp the cord and put the child on CPAP. Immediately clamp the cord and then perform initial steps, and then give positive pressure ventilation if the baby continues to be apneic. Delay the cord clamping by 1 minute and then give positive pressure ventilation. So this is for sure. I told you that if the child, any sign of compromise in the child, we will abolish this maneuver of delaying the cord clamping. So that means we have to immediately clamp the cord. So either it is B or C, because A and D are out of question. Now immediately clamp the cord and put the child on CPAP is again a wrong option, because I told you CPAP comes into play only when the child is breathing spontaneously, has its own respiratory efforts. Here the child is born apneic, so there is no point in starting CPAP over here. So what do we do? Obviously our choice becomes C, that we clamp the cord, perform initial steps, and then give positive pressure ventilation if the baby continues to be apneic, right? So now let us actually discuss the steps of neonatal resuscitation. So these are the latest updated NRP guidelines which have come in around, they were released around June 2020, and then they were made public by January 2021. So these are the latest guidelines. So what do we do? Let us see that. So first of all, this is the first step, antenatal counseling. The parents have to be counseled if we are expecting any unusual kind of thing depending on the maternal complications. Team briefing, whatever team is there to resuscitate the baby, and we check the equipment, that the bag is working properly or not, the mask is okay, of the adequate size of the expected weight of the baby or not. So this is what is done in the equipment check. After birth, we have to ask 3 questions: term, gestation, good tone, breathing or crying, right? So if the answer to each one of them is yes, that means everything is hunky-dory, very nice with the baby, and you shift the baby with the mother, and let the baby be with the mother. This will initiate the breastfeeding, and this will prevent the child, this will keep the child warm, prevent it from going into hypothermia, and the same time you can just rub the child gently, and everything is stable over here. But if any of the answer to the question is no, then what we do is we perform, these are known as the initial steps. Please remember that. So we warm, dry, stimulate, position the airway, and we suction if needed, and then we assess the child. If the child is apneic or gasping and or having heart rate of less than 100 per minute, we have to consider this as secondary apnea, and we have to start with positive pressure ventilation, bag and mask ventilation in this case, and we can attach the child to pulse oximeter and also to a cardiac monitor if needed. If let us say the child over here is not apneic or gasping, the answer is no over here. That means is having labored breathing or persistent cyanosis. That means now the baby is having its own breathing, but the breathing is not proper. There is some problem. So here comes the role of CPAP. I told you for CPAP, the spontaneous breathing is very necessary. Otherwise, it has no role. And this since 2015, CPAP has come into the delivery room. Prior to 2015, there was no mention of CPAP administration in the delivery room itself, but now it has been said that CPAP should be there and you can start then and there. So what we do is, if there is labored breathing or cyanosis, we position the airway, suction, we attach the child to pulse oximeter and we give oxygen, and then we can wait for a while. If the child is still having labored breathing, we can put the child on CPAP and then manage accordingly. But now let us come here. We have started the child on positive pressure ventilation and attach the child on pulse oximeter, and what we see is that the heart rate is still less than 100 beats per minute. So what are we supposed to do? We are going to do the ventilation corrective steps. So what question, I'll discuss the question later on. Let me first teach you this. So we will do the ventilation corrective steps, and we all know the mnemonic comes by the name of Mr. SOPA, MR SOPA. So what does MR SOPA stand for? Let us go there. So MR SOPA, so these are the ventilatory corrective steps. M stands for mask adjustment. R stands for repositioning the head and neck. Then we have to give 5 breaths and see whether the heart rate is increasing or not. Right? If there is a chest movement and the heart rate has increased, that means we have taken the ventilation corrective steps and we can proceed further in our resuscitation table. But still, if there is no chest movement, then we go to S. So what does S stands for? We suction the mouth and nose. Here comes a question. What is suction first? Please remember, M comes before N. So first mouth is suctioned and then nose is suctioned. Number 1. Number 2, you don't have to go for a very deep suction because that will elicit the vagal induced bradycardia in the baby. So your steps of resuscitation will go into vain. So please don't go for the very deep suction of the mouth. So that has to be taken care of. Then next is O, open the mouth, and we use finger gently to open the mouth, and we start giving breaths. Again 5 breaths have to be given, and we assess the chest movement. If the chest movement is still not there, then we go for the P. P is for pressure increase, that usually the increments are done in increments of 5 to 10 centimeter of H2O. The maximum pressure to be given in a term child is somewhere around 40 centimeters, and in a preterm child is around 30 centimeter of H2O, right? And again we give 5 breaths and assess the chest movement. Still if it is not there, then we go for an alternative airway. So alternative airway can be in form of laryngeal mask airway, or it can be endotracheal intubation. See, right now we were doing bag and mask ventilation, but here the child is not responding. Probably our way of doing bag and mask is not okay. So this child requires alternate airway, and that is either laryngeal mask airway or the endotracheal intubation. Right? Now let us see the one marker which will improve and which will tell you that your resuscitation steps are actually going well is the increase in heart rate to more than 100 per minute. Please remember this. This is asked in your exam, that what is the one single marker gauging the efficacy of effective resuscitation? It is heart rate more than 100 beats per minute. Right? So let us come back to our resuscitation protocol. So we have ensured the adequate ventilation by MR SOPA, and after 30 seconds of adequate ventilation, after MR SOPA steps we do 30 seconds, because that means we are actually seeing the chest rise. So we then continue with the bag and mask ventilation for another 30 seconds, and then we see whether the heart rate has increased to more than 60 or not. If it is less than 60 now, then you have to add on chest compressions. Please remember this. So what are the indications of chest compression is after doing effective ventilation. Effective means we have already done MR SOPA. So after doing effective ventilation for 30 seconds, if the heart rate does not rise beyond 60, please add on chest compressions. And here what we do is chest compression plus bag and mask, but usually it is seen that when we are going for chest compressions, then bag and mask is not the correct thing. Go for bag and tube ventilation. That means at this point when you are adding chest compression, better is you intubate the child. So this is how it is done, and at this point of time we increase the oxygen also to 100% oxygen. Now till now what we were doing, please remember, if we are resuscitating a term baby, then we just do bag and mask with 21% oxygen, that is on room air. And if we are resuscitating a preterm baby, then the percentage of oxygen used is somewhere between 21 to 30%. These are the new protocols which you need to remember. But once chest compressions come into the picture, then you have to increase the oxygen saturation to, you have to increase the oxygen delivery to 100% oxygen, that is by connecting the oxygen tubing to your this thing, and we have the blenders, and that in that blender we can see that the oxygen delivery is 100% over here. Then after 60 seconds of chest compressions and bag and tube ventilation, if the heart rate still does not rise above 60 beats per minute, then we have to go for medications, and the medication what we have in our hand is IV epinephrine. IV dose is, IV mode is preferred, so we have to go for IV cannulation. That can be done in the umbilical vein, or you can also go for intraosseous. But anyways, if this is not possible, if the peripheral cannulation is not possible, then what we do is for the endotracheal installation of the epinephrine. But please remember, endotracheal installation is not preferred because the delivery of epinephrine is very unpredictable. So we always go for the umbilical venous cannulation for giving epinephrine. Only if it is not possible, then we go for endotracheal installation of epinephrine. Now the question what comes is that the child is born, a newborn is born limp and apneic, and the heart rate is 40 per minute. What will you do? Now here most of the students commit a mistake. Seeing a value less than 60, they straight away go for chest compression. No, the answer is wrong. Please remember, if the newborn is born with a heart rate of less than 40 and you have performed the initial steps, then the next step would be doing bag and mask ventilation. That is the most important thing, otherwise you will get the answer wrong. So first bag and mask has to be tried. Even after effective bag and mask, if the heart rate continues to be less than 60, then only chest compressions come in. Chest compressions would not be the initial modality. Seeing the figure of less than 60, everybody goes for chest compression, and that is a wrong answer. So that you have to be very, very right in this, that whatever the figure is, if it is less than 100 and that is the first encounter you are having with the baby, please go for bag and mask ventilation. Even after effective bag and mask, if the heart rate is coming less than 60, then you add on chest compression, and even after chest compression, heart rate is coming less than 60, then you add on your epinephrine. Is that very clear? That should be clear now, right? So this is the target oxygen saturation level we should be knowing. We always go for the preductal estimation of the saturation. What is meant by preductal? We attach our pulse oximeter to the right upper limb, because the left upper limb and the both lower limbs are the postductal, would be supplied by the postductal circulation, and they can be misguiding. So your pulse oximeter should be attached to the right upper limb. So these are the steps of neonatal resuscitation which you should be knowing. Okay, then what is the next this thing over here? The next question over here is, okay, so this has come in your AIMS 2021. So I've taken the question from there. So at step A, all of the following are done except. So what is the step A? You have seen that apnea, gasping and heart rate is less than 100 beats per minute even after performing the initial steps. These are known as the initial steps. So after that, if this is the scenario, what do we do at A? So what do we do at A? Do we attach the child on CPAP, or is it pulse oximetry, start PPV, or consider connecting to the cardiac monitor? So the correct answer would be, obviously CPAP is not done over here. The child here is apneic, is gasping, is having improper respiratory efforts. I've told you again and again, CPAP will not work if the child's spontaneous respiratory efforts are inadequate. So CPAP is not the correct modality over here. Rest all three are correct. So the answer over here is going to be CPAP, because they have asked except, that is all is done except, then the answer is going to be CPAP, right? Okay, anything else over here? No, we move on to the next question. Okay.
28-year-old female with second gravida para 1 L1 at 38 weeks came to labor room with a history of decreased fetal movements for last 4 hours. Okay. Her blood pressure is normal. On per vaginum examination, cervix is 5 centimeters dilated. Vertex presentation, doctor did ARM, artificial rupture of membranes, which showed a meconium stained liquor, because lady has given the history of decreased fetal movements.
Ma'am, I will interrupt you right now. I just saw a question. So Zen mode has asked me, what is the compression ventilation ratio? Yes, it is 3:1. So 3 compression for 1 breath. Right, so 3:1 ratio, it is given. The compression ventilation ratio has to be 3:1. This is another question which is very commonly asked in your exam, and this you should remember, right? Okay, ma'am, please continue.
So please remember, in the OBS question there is almost the hint in the questions, and you will get your answer correct from the hints. Decrease fetal movement whenever written in the question, that means fetal distress. Okay, remember that. When it is written as absent fetal movements or loss of fetal movement, it means a dead fetus. Okay, so absent fetal movements or fetal heart rate not localized. Okay, fetal heart rate not localized. All these 3 lines or 3 sentences or 3 words, it means it is a dead baby. So always answer your question or check the correct option given by understanding the question. सबसे पहले आपको क्वेश्चन ही अंडरस्टैंड करना पड़ेगा. Decrease fetal movement is fetal distress, then mark your answer accordingly. Absent fetal movement, loss of fetal movement, or fetal heart rate not localized by the doctor, it means a dead fetus. Okay, now in this case, since it was on per vaginum examination, cervix is 5 centimeters dilated and there's a history of a decreased fetal movement for past 4 hours. So always first step of the obstetrician is to take a Cocker's artery forceps and perform artificial rupture of membranes, and the first thing that you will look at is the color of the amniotic fluid. If it is everything is all right, then it will be a clear amniotic fluid. But in this case, it is already meconium stained liquor, and your answer at this point of time cannot be go and proceed and wait for a normal delivery or give oxytocin. Oxytocin will increase the uterine contraction. Of course, it is a drug to augment the labor, but when there is contraction, already there is a compromised baby. Okay, there is already a compromised baby, and there is already a component of uteroplacental insufficiency, or there is, like hypoxia to the baby. That is why the baby has passed meconium. So giving oxytocin will further hamper the oxygen supply, and with uterine contraction, like if it is a thin or moderately thick liquor, it will become completely thick liquor. Baby can aspirate and there can be meconium aspiration syndrome, or baby can die. Now, rate of cervical dilatation in primigravida in active stage of labor is 1 centimeter per hour. So it will take almost 4 to 5 hours for complete dilatation, and then delivery will take, like second stage of labor maybe average 1 or 1 to 2 hours. So we cannot wait in that situation. So I am just going to prepare this for an immediate cesarean section in view of meconium, in view of hypoxia. Now, this is NST. NST is done when we want to prolong the pregnancy and we are waiting for a fetal lung maturity. And there was a question in AIMS, identify what is this machine. So it is an NST machine. Now, biophysical profile is important if it is an antenatal case, but this patient is already in labor. Now, what do you understand by biophysical profile? We go for a 5 important parameters, that is NST, amniotic fluid, fetal tone, fetal breathing movement, and gross body movement, and we give 2 score to each of the parameters. So normal score is 10 by 10. Now, the fetal biophysical activities are initiated, modulated, and regulated by fetal nervous system. If there is hypoxia, there is metabolic acidosis, which leads to CNS suppression, and there is changes in the fetal heart activity. So meconium aspiration, ma'am is going to discuss better, because I will emphasize on this fact, since it is in active labor, we do not augment. Of course, there is a surgical augmentation of labor we have done by ARM, but it has to be a clear amniotic fluid, then we can just do the wait and watch, because this baby will deliver. But it is a green color Lycal meconium stain, so I am not going to take up a risk, and I am going to do a cesarean section. Now, NST parameters you should know: baseline fetal heart rate, beat to beat variability, presence of fetal heart acceleration, and no deceleration. Here there is no concept of NST in this question, because NST is done when you are wanting to prolong the pregnancy and you are waiting for fetal lung maturity. In labor, we do CTG, that is cardiotachograph monitoring, which is relationship of uterine contractions to fetal heart rate. So this is the CTG, and similar parameters we see. This is the normal CTG image. Okay. But our question here is a meconium aspiration. So I hand over this to Dr. Deepali to explain meconium aspiration and what are the steps and what are the risks involved.
Okay, so a newborn of 38-week gestation, ma'am has delivered, born through meconium stained Lycar. All of the following statements regarding this newborn are true except. So bag and mask ventilation is contraindicated in resuscitation of this neonate. Respiratory distress might develop in this child within the next 6 hours. This child might require sildenafil or inhaled nitric oxide to treat persistent pulmonary hypertension of newborn, that is PPHN. And air leak syndromes like pneumothorax and chemical pneumonitis are expected complications in this scenario. Okay, so we are dealing with meconium, a baby who's born through meconium stained Lycar, and there's a high possibility that the child has developed meconium aspiration syndrome. So the child would be born limp and apneic, and we have to resuscitate this child. Please remember that, of course, because if the meconium aspiration has occurred, the child is going to develop respiratory distress in the coming 1 hour or 2 hours or so. And the meconium injury actually occurs in 3 modalities. So that I am going to explain to you, and one form of injury is by the development of PPHN. Please understand this, the children of meconium aspiration syndrome usually never die because of mass. They die because of PPHN. This is the most dreaded complication and a neonatologist nightmare to handle. And PPHN is, I will just explain to you, right? So yes, sildenafil and inhaled nitric oxide are used to treat PPHN. So that's a correct statement. And air leak syndromes are also common, that I'm going to explain to you. So here the answer is that the bag and mask ventilation is contraindicated. Yes, it used to be contraindicated when we were at your age. That means when we were studying this thing for the PG entrance. And during my MD also, we were taught that bag and mask ventilation should not be done for the fear of pushing in meconium into the, even if the child has not aspirated meconium, your maneuver of doing bag and mask ventilation would actually turn a normal child into a meconium aspiration syndrome. But now studies have shown that this is not the case, so you can very well do bag and mask ventilation in resuscitating the child. So please remember, no longer bag and mask ventilation is contraindicated. There is one contraindication that you have to remember, and that is congenital diaphragmatic hernia. If you know antenatally that the child to be born is of congenital diaphragmatic hernia, then you are not supposed to do bag and mask ventilation. You have to go straight for bag and tube, that is intubate the child and go for bag and tube ventilation. So that is the only contraindication that exists for bag and mask ventilation. So that you have to remember. Now let us come on to how does meconium harm the baby. So you know meconium is composition is of green, blackish green kind of liquid, a pasty kind of liquid, and usually it is composed of some lanugo hair, some desquamated cells and bile. That combination of all this gives rise to meconium. Now this meconium, if taken up by the child, results in something known as chemical pneumonitis. So that is one form of injury that this meconium, by virtue of its chemical properties, leads to release of cytokines, and this cytokines obviously would, they are a part of inflammatory cascade, and this would lead to chemical pneumonitis. That is one form of injury. The other form of injury is meconium would go and block the airways, and usually it goes and blocks the terminal airways and causes a ball valve type of effect. So what happens is there occurs atelectasis of the alveoli, and also there occurs air trapping. This you have to remember, that air trapping is a very important kind of development which takes place in lungs because of the meconium partially obstructing the airways. So air trapping occurs, and some of the alveoli actually collapse because there is no air going inside it, right? So that is another form. And the third form of the injury which meconium does is that by virtue of causing severe hypoxia to the child, the pulmonary vasculature, a very important development that takes place during birth is that the pulmonary vasculature has to relax, and then only the fetal circulation gets converted to adult type of circulation, the lungs start functioning and the gas exchange is established. If the pulmonary vasculature does not relax, then the child would be in trouble because there will be severe VQ mismatch. That means ventilation is occurring because the child is breathing, but there would be no gas exchange because all our capillaries abutting the alveoli are in a constricted state. So this is known as persistent pulmonary hypertension of newborn, and one of the reasons why vasculature does not relax is the presence of hypoxia. That hypoxia can be because of any reason, but here we are discussing mass, and mass over here is the reason why hypoxia occurs and does not let the pulmonary vasculature to collapse, and hence the child develops the dreaded complication of PPHN. So definitely to get these vessels relaxed, we have to use the pulmonary vasodilators, which is your famous drug sildenafil, and of course inhaled nitric oxide. So they come to rescue, they help in relaxing the pulmonary vasculature and mitigating the VQ mismatch. Is that clear? Now what about chemical pneumonitis? This heals as the time progresses. Now here comes a very important question: do we start antibiotics in a child with mass or not? This question actually comes in your exam. So the standardized textbooks tell you that whenever an infiltrate develops in a child having mass, we don't come to know that whether that infiltrate on the chest x-ray is because of the meconium aspiration or is because of some secondary sepsis resulting in pneumonia. So it is always wise to start antibiotics. This has come in your standardized textbooks, so this you have to note it down, that antibiotics are very well indicated. Another big thing which has come into textbooks nowadays is the use of surfactant. So that is what we have been doing also practically. That's usually meconium, it induces the deficiency of surfactant. It does not let the surfactant act. So this is kind of a secondary deficiency of surfactant. So giving surfactant has also now got a big role to play in the management of mass. So this you should remember. Now what about the air trapping? Because of the air trapping, there air occurs, air leaks, the alveoli they rupture. So these children are prone to develop emphysema. They are prone to develop pneumomediastinum or pneumothorax. So therefore air leaks are very common because of the air trapping, and because of air trapping, use of CPAP has to be done with caution in mass, because CPAP will worsen the air trapping. So that is why CPAP is not a very preferred modality. You should know it has to be used with caution. We usually do not put the child on CPAP while managing a case of mass. So this should be very clear with you. So these are the three types in which meconium aspiration can harm the baby. So let us now do the other question. So all of the following are true in mass except surfactant replacement is recommended. We know this now. CPAP is to be instituted with caution. Chest physiotherapy is an excellent adjunct to therapy in the initial phase of management to clear meconium from the airways. Yes, we'll be tempted to do it, but please remember it should never be done. See, the best thing what you can do for a baby with mass, always remember this. Let the child be. When the child is on ventilator, don't touch the child that much, because any kind of crying, any kind of stimulation would worsen his PPHN. We don't want that. We in fact want the PPHN to be reversed. So that is why let the child be. It's a kind of no touch policy. So therefore chest physiotherapy will be deleterious to the child if done in the initial management. Later on, when the child is quite stable, is recovering from mass, then we can do this. But the initial management, the child is not to be touched that much, not to be disturbed that much. So therefore, chest physiotherapy is not a very good idea during the initial management of mass. And steroids are not recommended in the management of mass. Yes, this is very true, because they are in fact of no use at all. So what is the all of the following are true except, so what is the incorrect statement? The answer is that chest physiotherapy should not be done, and it is over here, it is given it is done. So that is why this is the answer over here. I think we are done.
Yes. I hope that the session has proved to be useful to you,
and
so
fruitful.
do prepare well for your exams, and these are something which is like very, very important topics. Of course, high risk pregnancies and their management, but how it can be integrated with the pediatrics. Okay, that's what we try to give you a proper guidance. Okay, so that's all from me and Dr. Deepali's side. So all the
Goodbye, all the best. God bless.